the coronary semifinals number 4. So I'm RSC Marin. I'm from the Medical University of South Carolina, Charleston. We are waiting for my co-moderator, Dr. Thomas Holland, to join, but we are joined by Dr. Timur Paul, Dr. Tim Mixon, and Dr. Saroj Nirupane. For the sake of time, we can go ahead and get started with Zainab Dakhil, when the heart takes a hit to myocardial infarction in a multiple trauma patient.
Hi everyone, and thank you for the CVI for giving me the opportunity to present my case, which is when the heart takes a hit to myocardial infarction in a multiple trauma patient. Speaking to you, Zainab Dakhil, an academic and interventional cardiologist from Iraq. I have nothing to disclose. So the case is a 42-year-old male who was heavy smoker and had a motorcycle accident by hitting the wall. At the emergency department, the patient was unconscious with a Glasgow Coma scale of 8, and he has spontaneous breathing, a blood pressure of 80/50 millimeter mercury, and his heart rate was 50 beats per minute. He has soft abdominal blunt chest trauma, clear chest, lacerated wound in the scalp with depressed skull fracture in the parietal bone. So as part of the workup, the patient had chest X-ray and CT brain, and the patient had depressed skull fracture, subdural hematoma, exerted some pressure effect on the brain. For that, the neurological team decided to intervene. At the theater, while the patient was on monitor, pending to have the intervention for neurosurgery, it was noticed that the patient had a heart rate of 36 beats per minute. An ECG was requested. Within the ECG showed that he has complete heart block, ST elevation in inferior leads, also in the anterior leads, and he has reciprocal changes. So the concerns were whether the ECG changes were central from the CNS trauma rather than a cardiac effect, and can the impaired consciousness that the patient presented with actually due to cardiac cause of the heart block and the ischemia rather than due to the central cause of the subdural hematoma. With further discussion with the neurosurgical resident, he said that the subdural hematoma was not sizable enough to cause the pressure and cause the impaired consciousness that the patient presented with. The hospital was outside the capital. There was no catheterization lab within the hospital setting, and an external cardiac team was consulted from the private practice. The echocardiography showed trace pericardial effusion and excluded any evidence of aortic dissection. The patient was referred to the other hospital with the active cath lab. It was a private practice, and the patient, as being a critically ill patient, it was very, very important to have a thorough family discussion for having the complete consent, and proper communication should be done in such case. So this is the coronary angiography that was done for the patient. And we can see here that there is a long LAD lesion, but it was not the Culprit. And there is, sorry. Sorry for that. How to just only the video, please?
Can you click on the video images, please?
Yes, thank you. So, and there was a distal total occlusion of the RCA. The vessel, all the vessel appeared small within the RCA. So whether it was a coronary vasospasm or it was a dissection involving the right coronary artery, this was the question. However, once there was introduction of the wire, there was restoration of the flow. As the patient was shocked, it was not proper to give nitroglycerin and exclude vasospasm and so on. So the operator went directly with stenting and direct PCI of the right coronary artery. The other issue here is whether we should have done the intracoronary imaging or not. And the other issue is the concern regarding the dual antiplatelet for such patient. Should only having restoration of the TIMI3 flow without stenting should be done, or the stenting was the right issue here? So this is the ECG after the primary PCI was done, with complete resolution of the STT changes and also with resolution of the heart block. A wire introduction through the lesion restored the blood flow in the RCA, which contradicts that this is a right coronary artery vasospasm. And the patient consciousness during the procedure substantially improved, which also goes with that actually the cardiac effect is the cause for disturbed level of consciousness of this patient rather than the central effect. And the risk-benefit issues were assessed during the RCA, so direct stenting was done despite the concern regarding the expansion of the subdural hematoma. 2 hours post-PCI, there was complete regaining of consciousness. Within 2 days within the cardiac center, the patient was stabilized, and after that, he was referred back to the other hospital for a neurosurgical ward admission, and the patient was discharged well after that. The cardiovascular disease and major trauma are both leading cause of death and disability. Trauma is one of the non-atherosclerotic factors that associated with acute myocardial infarction, particularly among young patients because they are prone to the accidents. Older age coexistent atherosclerosis may contribute to the appearance of acute myocardial infarction following a traumatic episode. It's commonly associated with a blunt chest trauma, and the LID actually is the most common artery to be affected as a culprit lesion for acute myocardial infarction. Around 76% of cases of acute MI following a blunt chest trauma followed by the RCA, and usually within the proximal thirds. The mechanisms of acute myocardial infarction post-MI are diverse, including the intimal dissection with resultant thrombosis, vessel rupture, fissuring of pre-existing atherosclerotic plaque, and embolism, also vessel vasospasm at the site of direct mechanical injury. Actually, all the aforementioned concerns are concerns that can occur for any of us, but being in Iraq, there is another concern is whether to take action in such patient and really intervene in such patient or not. In Iraq, there is an issue of lacking of law backup to protect the doctors. Also, with a collapsing healthcare system and the lack of pharmacotherapies and the high volume patients within the centers. One of the issues that we are facing as interventionists is usually it's very difficult to intervene in very high-risk patients. There is what's called the tribal virgils, or what's called the family vendetta. It's very common in Iraq and many Middle Eastern countries. So if we take a patient who is at very high risk for the procedure, the interventionist is usually afraid from what will happen if this patient has any complication. And it's very common, it's very common that the interventionist will face certain consequences for that complication or even the death of the patient, even if these events actually were inevitable. And that's why it's very important for a healthcare system to be supportive for the physicians and interventionists especially, so that only the guideline, only the science can guide their intervention rather than the cultural or traditional customs and other environments. So dealing with a complex patient here is really the issue rather than dealing with a complex lesion. So the key learning point for the operator and team is myocardial infarction after trauma is rare but still a serious complication. Every patient with multiple trauma, especially if a blunt chest trauma is included, should be investigated for cardiac injury as early as possible to intervene if appropriate, to have low suspicion index for cardiac injuries after multiple trauma, even while treating young patients without really remarkable cardiovascular risk factors, and also to intervene appropriately even for the interest of the patient, even if there was a risk, and even if the cultural customs against the doctor, because as Voltaire said, we are all guilty for all the good that we didn't do. Thank you very much for your time and attention.
Any question from the panelists?
Do you guys have drug-coated balloon in Iraq?
Sorry?
Drug-coated balloon? Do you guys have it available?
No, actually, it's very limited, and especially in private practice, it's not really common to use such things.
I guess someone with high bleeding risk and then right coronary artery, you could potentially argue could be treated with drug-coated balloon if you get a good PTCA result, and that was the reason I was asking that.
That's an excellent case. Really complicated to figure out, what was the cause of the bradycardia, and I'm wondering, certainly trauma can lead to MI, but it seems like in this case it might have been the MI leading to the trauma.
Yes, it was one of the things that we think of retrogradely, because during the description of the accident, what we understand there was the patient hit the wall, but still the pericardial effusion, that was really something, it's not common during MI.
All right, for the interest of time, thank you so much, Zainab.
Thank you very much.
So our scoring system is going to be from 1 to 5, 5 being the best and 1 being not so the best. So, and we will come up with a thing. So, Doc, I would like to invite Dr. Aaron Shaikh to give a talk on full revascularization.
My name's Aaron Shaikh. I am the outgoing CHIP fellow from University Hospitals of Cleveland. This is a case I want to present here, if I can get this going. Okay, all right, so I don't know why I did that. I'm sorry, I went the wrong way. Can I go back? Can you guys scroll me back to the beginning? I don't, I guess I used the big button.
Sure, pass it to it.
Okay, no disclosures. All right, so this gentleman was 85-year-old who presented with acute chest pain and dyspnea, ruled in for an STEMI with a significantly elevated troponin. He actually presented to an outer satellite hospital that and then was referred to our center for surgery versus complex PCI because of the lack of capabilities of those at the other hospital. His pertinent other history was he had carotid artery stenosis. He also had hyperlipidemia. He was statin intolerant, and he was maintained on Zetia. So he had a normal EF. Well, actually, his EF was now reduced. It was previously normal, global hypokinesis, and no significant valvular abnormalities. He comes for diagnostic coronary angiography. You can see here on the left, there's a dual LAD system involving a CTO of that long diagonal branch and a Medina 111 with the LAD and that bifurcation diagonal. The circ has disease in the prox in that OM1 and that OM2, and the RCA is diffusely diseased, severely diseased. So unclear culprit, which is common with NSTEMIs and multivessel coronary artery disease in this elderly gentleman. So the clinical challenge here was surgery versus PTI, or PCI, excuse me. We had a heart team discussion. He was deemed to be a suboptimal candidate given his age, frailty. He was pretty slight in stature, so he was considered to be a high-risk surgical candidate, plus the patient and his family's preference was PCI if possible. So he was referred for percutaneous revascularization. And then the question for us now was complete versus incomplete revascularization. A gentleman with severe complex multivessel coronary artery disease involving a CTO, and whether or not we should, if we're going to completely revascularize, should we do it in one procedure or should it be staged, and then how to stage and how to really plan this procedure out. So going to go back here. Can I go back one? Okay, so our plan up front was to basically rule out left main disease with the IVUS, tackle the circ, do the CTO, then do a DK crush in that LAD, and then stage the PCA for a later date. So we set up with 7 French radial access, wired the circ in the LAD, did the IVUS of the LAD back in the left main, and IVUS of the circ back in the left main as we planned. You can see the top frame, that still frame, is the left main, showing we got about a 5.0 millimeter vessel, pretty free of disease. Distal in the LAD was a 3.0, 4.0 prox, fibrocalcific disease. There was an osteal landing zone, and like I said, the left main had no significant stenosis. We did an IVUS of the circ from the OM1 back, and we had a distal reference value of 2.5, again, fibrocalcific plaque. In the osteal circ, there was an MLA of 6.4 millimeters squared, so we figured we could spare the ostium of the circ. And so PCI of the circ started, we put a run through down that OM2. We treated the OM2 with one drug-eluting stent, post-dilated it 2.5 and 3.0 distally approximately respectively based on IVUS. And then we then wired the OM1 with a Monamo based on our IVUS assessment there. We pre-dilated with a 2.5, put two overlapping DESs, and the proximally overlapping one went into the proximal circ. We post-dilated based on our IVUS assessments with 2.5 NC and a 3.5 NC at 22 atmospheres. And that was our final result for the circumflex. So the next step then was to, oh, here's our IVUS here, sorry. You can see this is the IVUS coming from the OM2 back into the proximal circ. It looks like the stents, it's oval, well expanded. There's no malapposition as well. Okay, so the next move was then to tackle the CTO. Just sort of characterizing it, had a blunt cap. It was a relatively long CPO, greater than 20 millimeters. Good distal vessel quality. There's an epicardial from that LAD. So our plan was to do antegrade, to cross antegrade with a retrograde wire as a just marker. If not, we would go retrograde. If not, ADR. And then finally, we would consider an investment. If we did cross, we were going to do our LAD diagonal bifurcation stenting, as I talked about earlier. So just going through the CTO algorithm, we didn't need dual angiography, but we did look at the angiogram carefully, of course. The proximal cap was somewhat ambiguous. There was good vessel quality, so we decided to go antegrade wiring. If that didn't work, we'd go retrograde. If that didn't work, we'd go antegrade. If that didn't work, or if that did work, then we were successful. If not, we would consider this as an investment procedure. And this is the global CTO algorithm. Okie dokie. So we ended up wiring the epicardial with a Xi'an blue. We were able to cross that proximal cap with a Gaia next second and a Corsair microcatheter, navigated the CTO with a Pilot 200. We then punctured the distal cap again with the Gaia next second and entered the true limb, and we confirmed that in contralateral projections, and also we was dancing with our just marker there. We then advanced the Corsair microcatheter, removed the workhorse, removed the Gaia, put in a workhorse wire, and then pre-dilated the lesion with a 2.5 semi-compliant balloon. This is our IVUS here. Is basically we were intraplaque mid and distal. You pull back, you see we're extraplaque proximally. There's primarily fibrocalcific disease, and our distal and proximal reference measurements are noted there, 2.5 and 3.0 respectively. So then we do, based on our IVUS, we stent with two overlapping stents in the diagonal branch with the proximal ones coming into the LAD. We post-dilate in the diagonal branch. We then do an IVUS-guided crush, DK crush. So basically, we crush the diagonal stent, we kiss, we stent, and then we kiss again, and then we pot. And this is our final results after IVUS looking into the diagonal, needing some more non-compliant balloon expansion. But this is our final result of our DK bifurcation and our CTO PCI. And then this is just sort of what he left the hospital with on the post-op day one the next day with this result, at least from the lab, I'll say from the lab. All right. And so now the move was to bring him back 17 days later to do the RCA. But we're diligent, and so we're going to look at our work from previous. Our stents on the left system look open, TIMI3 flow. There doesn't look like there's any issues there. I'm sorry about the jumpiness of the angiograms, but you can see that everything looks pretty much as we left it. So then we do the RCA with a 3.5 drug-eluting stents under OCT guidance. All right, and so this is basically what he's left with, this 85-year-old gentleman who came with an STEMI and a new cardiomyopathy after being turned out for surgery. So this was not the most complex case I did in my CHIP fellowship, but I liked this case because it was a hell of a lot of fun to do. As you can, there's a lot of techniques, and DK crush. It's the playground of an interventional fellow. But there's some nice teaching points, particularly the heart team approach. It's multidisciplinary for clinical decision making, especially in this gentleman who is elderly. We evaluated the patient in a global manner, not just his syntax scores, STS scores, but took into account his frailty, his preferences, his family preferences. Our recommendations were based on his preferences and his overall global assessment. And also the heart team can consider non-revascularization options, including medical management or palliative care in more very advanced sick patients. Another key learning point of this case was operational planning, which was huge here, essential to achieving the full revascularization with an optimal result and reducing our risks of complication or failure. Really need to be diligent about how we're going to tackle these multi-vessel complex cases in elderly patients, and actually all our patients. So our plan, as we had, we followed it. It worked, thankfully. We used our algorithm approach to cross the CTO. We dealt with the bifurcation, and we then staged the PCI of the RCA. With that planning, we were able to reduce radiation exposure, procedural time, dye administration, operator fatigue. That's a huge one. And that led to a reduced risk of complication, failure, promoting achieving an optimal result with this elderly patient with complex disease. Finally, CTO operator skill set was very essential for getting this particular result. CTOs are often present in a lot of surgical turndowns. In my CHIP fellowship, seemed like every other patient we had who was turned down for surgery had a CTO that could have been evaluated for revascularization. CTO PCI should be available to our patients when surgery is not feasible, and CTOs are present in the anatomy. And then consider referral to a CTO operator if that skill set is not present in your lab, like this patient was brought to us. And then finally, CTO skill sets can be learned by operators across the spectrum of career stages. I'm living proof of that. And this is our final angiogram there. I'll stop for questions. Thank you.
That's fantastic, and that's as complex as it would get in CTO PCI and complete revascularization, epicardial collateral wiring, etc. Was his EF normal, or
it previously was, and then when he arrived with the STEMI, it went from normal to 45% global hypokinesis.
Thank you. Any other questions?
What was the creatine, baseline creatine?
Oh, all his labs were normal. His hematocrit was normal. His creatinine was normal. All of his liver function was normal.
Yeah, that was going to be my question about his renal function, and that,
of
course, plays into your decision-making as well, doesn't it, with respect to how much you do. What did you think his culprit was? And very nicely done, by the way. Yeah.
I mean, thank you. Could it have been the RCA that looked like it was sort of the fresher lesion of all of them? The circ was severe. There was nothing that looked thrombotic, and then you have a CTO, and it's somewhat calcified in the LAD. These STEMIs, it's oftentimes you don't know the culprit. If I had to bet my money on it, it could have been the RCA, but I don't think there's any way to really parse that out.
So that I think brings me to my point, which is, was that the last vessel to do if you thought that was the culprit? And was the CTO really the most important thing in this 85-year-old man at the beginning? Or perhaps if you don't have that CTO skill set, maybe you do the other things.
Exactly.
And then wait and see how he does, and perhaps bring him at another stage to focus on the CTO, which is probably not his culprit, I suspect.
Exactly, yeah.
Thank you, Erin. Let's go to the next case. Breaking through, an approach to a perforated vein graft. Eric Lemieux.
Lemieux, like the
Eric
hockey player.
Lemieux.
That happens a lot. I'm Eric Lemieux. I'm one of the general.
In Canada, wouldn't.
Sorry, what was that?
Not in Canada, wouldn't.
I'm Eric Lemieux. I'm one of the general cardiology fellows at Baylor University Medical Center in Dallas, Texas, and I'll present a case of a pesky vein graft problem. I want to thank everybody here, even late in the day, for coming to join this presentation. So, all right, I have no disclosures for this talk. So I'm going to present the case of an 80-year-old woman. She came into us with CCS class 3 angina. She has a history of peripheral vascular disease. She had a FEMPOT bypass on the right in 2005 that treated her well. She has CAD. She had a CABG 10 years ago, 3 vessels. She also has a history of hyperlipidemia, but her latest LDL on presentation was 51. She is a non-diabetic. She does have hypertension. She had originally presented to us 8 months ago, similar symptoms, really a dyspnea-type angina presentation. We got a left heart cath done, and we stented a PDA, the SVG to the PDA with resolution of her angina. But then 2 days prior to her presentation, this time to the lab, she came back to clinic feeling awful, the same shortness of breath. And this is a lady who does not exaggerate her symptoms. She does not like being in the cath lab, so we take this very seriously when she came in, and we decided that we want to do a left heart catheterization, possible PCI, and given her right FEMPOT bypass, we were going to go via a left femoral approach. Here are native vessels. I won't belabor much. As you can see, she needed the CABG desperately. I've only presented the OM graft here, but we did shoot the Lima and the LAD. That was patent. The SVG and the PDA, which had a prior stent 8 months ago, was also patent. And on the left here is the vein graft to the OM as pictured in April of 2024, her first catheterization. As you can see, 8 months later in December, she presents with a proximal lesion to this vein graft as well as a tight mid lesion to this vein graft. So for our plan, we didn't feel there was 2 to 3 centimeters in the vein graft outside of the native vessel for a filter wire, so we were going to direct stent this, the flow-limiting distal lesion, and then we also wanted to stent the proximal lesion, so we chose a less aggressive JR guide in order to facilitate better stent placement of that first blood vessel, or the earlier disease. This is the first image taken after that 3.5 by 22 PCI, and as you can see, we have created a problem. We have a perforation in that vessel. So bringing us to our clinical challenge, how to manage perforation in a vein graft. So in general, management of any perforation, that's all about stopping the bleeding. All of these steps are to facilitate stopping the bleeding. Initially, you're stopping the bleeding as soon as possible to support the patient, make sure you're not losing blood, causing tamponade. You're going to use pressors, volume, sedation if they're having pain. This is a vein graft, so you don't know if the bleeding's happening in the pericardial space or if it's happening in the chest cavity, but you're monitoring the vitals closely and you're asking for extra hands if you need it. And then the plan eventually is going to get to a covered stent to give you a more permanent fix of the active bleeding that you've caused. And at the end, you got to check your work, because if you're still having extravasation, you still have a problem, and you may need to either go back with more covered stents or you may need a surgical repair. So that's what we did. So we immediately balloon tamponaded. We used a 3.5 compliant balloon to do that while we were asking for a covered stent. And then we tried to get the covered stent in, and it wouldn't advance past the proximal disease. So at this point, we're really kicking our guide choice. We wish we had a little bit better support, but we got to make the best out of the situation. So we used the 3.5 compliant balloon as a distal anchor in order to get a telescope past the proximal disease, which did work, and it allowed us to get our covered stent where we thought we needed to get it to cover this perforation. So this is a picture. I think I need help playing this video, because it actually is a video, but you can see this is a covered stent where we thought it was going to placed well, it was going to cover that perforation for us. And you might be able to see some brewing problems here that are better pictured on this next slide. So after we deployed that papyrus stent, we have more problems. So we started with a tight lesion or two. We still have a tight lesion or two. We caused a perforation. Now we have 2 perforations, and we have a proximal hydraulic injury dissection in this vein graft. So now we have problems. We started with problem. Now we have problems. So managing the perforation, that's still the same. You got to stop the bleeding. Preventing further injury from the hydraulic force, that's limiting injections. So you have a guide extension catheter, you know that you're at risk to cause hydraulic force, so the first things first is to stop taking pictures, don't add more contrast, don't make the problem worse. And then we still had the perforation, so we were still using covered stents to cover all the perforation and hopefully cover our dissection site as well. And then again, we don't know where this bleeding's happening, so monitoring the hemoglobin closely. And this person is not going home after the procedure as originally planned. So we were able to place further stents. We used 4 stents, 2 3.5 stents, and then 2 4 stents layered kind of proximally in sequence to cover as much as this is possible. And then we took a very cautious picture here. Fortunately, it looks like we don't have any residual perforation, and the proximal dissection does look better. So at this point, we planned and we did a regular non-covered stent at the proximal part of the disease. And this is the result we had. And we kept the patient overnight. We did an echo. She didn't have a pericardial effusion. She had resolution of her symptoms. She went home the next day, did very well, and months later, even in clinic, she's not complaining of angina anymore. So the learning we did from this case is when you get yourself into trouble, you got to be able to get yourself out of trouble. But first of all, don't cause more trouble. So if you have a hydraulic force injury from your guide extension catheter, stop injecting, don't make it worse. And then the second learning point is even if you place your covered stent perfectly over a suspected perforation site, that doesn't necessarily mean you're going to cover the perforation, because these things can travel through the vessel. And so always check your work. And in fact, we saw that we had not covered our perforation site well on the first time. And then the last thing is we didn't use IVUS in this case. We estimated that we would be half size down based on just site. IVUS sizing can lower the risk of perforation, but sometimes even if you IVUS size perfectly, you can result in a perforation due to internal calcium. And that's all I have. So thank you for your time. Thank you for listening. And I'll be happy to take questions.
So, Eric, you made a big mistake. You gave us time to ask you questions.
I'm ready.
And now you're
Let's
in trouble.
do it.
I'm a CTO operator, and I hate stenting vein grafts. And obviously, this patient with the amount of calcium doing a retrograde CTO PCI may not have been my first choice. But your stent was oversized in the first place, right? I think that was the first problem.
I agree. It probably was we were probably a little too aggressive with the first stent choice.
And even with your covered stent, covered stents are very tricky. I'm sure everyone has that thing. And to localize the site of perforation is even more tricky. And sometimes two views, even though you don't want to take more pictures and cause a bigger tear, but when you are placing the covered stent, it's worth your while because you already have a covered stent to take two orthogonal views, maybe increase your frame rate to 30 frames per second to kind of localize your perforation site, and then deploying your covered stent could help you. And the point with the guide extension. If you have a guide extension, you are giving very gentle puffs as well. Okay. Any other comments from?
I agree. Those are great comments. To the point of the sizing, the problem with vein grafts is it doesn't necessarily follow. If you're looking at an LAD, it's probably biggest proximally, and it's going to get smaller and smaller and smaller. So you can it's just not true with the vein grafts. So, you may see a big area at the top or the bottom. That doesn't necessarily imply that where you're stenting. So intravascular imaging there, I think, can avoid that. I think that's a great point. And then probably didn't have it at the time, but now we have the Ringer perfusion balloon. That would be a great situation to put it up to kind of give yourself some time to analyze the films, catch your breath. I think that's so important. When you get into complications, your brain's going a mile a minute, and sometimes I look back on the decisions I make, and I think, I probably wouldn't have made that exact decision if I had been calm or if I had, had a moment to gather my thoughts. So, phoning a friend, getting somebody that's not so emotionally involved is a great idea. And then if you can buy some time, I think my decision making tends to be better when I have a moment to analyze it.
I did learn about the perfusion balloons earlier this conference, and I was like, wow, that'd be useful. We need to acquire some of those.
You couldn't deliver the papyrus, so I think it would be really hard to deliver the Ringer balloon through this vein graft.
Sure, that could be, that's a fair point.
It is a good tool to have in the cath.
It's not working. I just want to clarify that you said that you did IVUS or you didn't do IVUS?
We did not IVUS during the case. Before, we planned to just direct stent based on sight, and then at the end of the case, we wanted to get out of Dodge. We hadn't caused.
And your plan was to fix the prox lesion anyway, right?
Yeah, we were planning all along to fix the proximal lesion.
Another teaching point is if you are planning to fix the prox, you should probably pre-dilate everything and before you just start to laying a stent distally because of this particular reason. If you create a disaster downstream, then you have proximal lesion that you need to deal with. So that's why there is a rule of thumb. We do have to stent some very few times distally without modifying proximally, especially if it caused a disaster. But in cases like this, you had times where you could have balloon proximally and modified, then you wouldn't be struggling delivering a cover stent.
Yeah, that's a great point. Not something I considered up front, but yeah.
All right, thank you. Thank you so much.
Sure.
All right, let's have the next speaker, Andrea Soares, Inferior STEMI. Where is the culprit?
Hi, everyone. My name is Andrea Soares. I am the current interventional/structural fellow at UC Davis in Sacramento, California. I just want to thank Dr. Kesarwani, my mentor, and Dr. Vijay Agusala, one of our general fellows, who's also here today. So this is our case, Inferior STEMI. Where is the culprit? I don't have any disclosures, but this is the website for all the faculty disclosures. So the reason for evaluation, this patient was a 77-year-old male. He actually presented from our local VA. They are not, they don't do STEMIs there, so they transferred the patient to UC Davis. He had been having chest pain and shortness of breath for 3 days. you know, a lot of times when we get these patients, we don't get a very thorough history. So all we knew was that he had had some kind of bypass grafting surgery done 26 years prior to his presentation here. He was transported by ambulance from the VA to our medical center. While he was at the VA, he was developing intermittent heart block, so they put him on a dopamine drip, they stabilized him, and then they transferred him with the flight nurse on the ambulance to help manage the drip. So when we started getting access, he actually became even more sick and started throwing up. So we knew he was definitely in some kind of shock. His heart block had stabilized with the dopamine, so we did a quick right heart catheterization. As you can see, he had elevated right and left-sided filling pressures, some mild, moderate pulmonary hypertension on that right heart cath. So we quickly decided to place an intra-aortic balloon pump to unload the LV. Obviously, it's not as powerful as an Impella, but he was a small man with small femoral vessels, so we thought that a balloon pump would be adequate, and indeed, in this case, it did prove to be. And then we went on to proceed with coronary and graft angiography. So here's the picture of his right. It's severely diseased. Functionally, it's sort of like a CTO. There's epicardial collaterals there. And then this is a shot of his left main, which is also very small. You can see that there were graft markers. So we were very relieved to find that, since we didn't know exactly what had been grafted. So his lima to his LAD was patent with some collaterals that you can see there filling from the apical LAD. The vein graft to the diagonal was 100% occluded, and then there is a vein graft here to the OM that has a severe 90% lesion that's kind of shadowed there by that third suture clip. So our question here is, where is the culprit lesion? What should we fix first? You know, we already had done a right heart cath and put in upfront support. The patient was more stable, so we had a little bit of time to kind of figure things out. So we actually decided to intervene on the vein graft first. So we used a 6 French LCV guide. We wired it very easily with a BMW wire. We just pre-treated it with a 2015 semi-compliant balloon. And then we deployed a 2518 Xiant stent. His pressure requirement decreased, but he continued to have chest pain. He continued to have persistent ST changes. So we went back and looked again at the left coronary system. And as you can see, you know, we've been giving him heparin, so you can see there's a little bit more thrombus now present in the circumflex. So we put a 6 French launcher JL35 guide in. We initially tried to wire that lesion with a BMW, but it actually would not cross. Since he had been having the chest pain for more than 2 or 3 days, we realized the lesion might be somewhat subacute. We did manage to cross with a Fielder FC. We quickly put in a wiggle wire through the microcatheter, and then we went on to pre-treat the lesion with a 2015 semi-compliant balloon and an angiosculpt, and went on to stent with a 2533 Xiant stent that we post-dilated to 3.5 proximally and 2.75 distally, and we have a really nice result there. So our key learning points for this case were for STEMI PCI in patients with unknown bypass anatomy. So one is door to unloading. If the patient is in cardiogenic shock, you can consider doing a right heart catheterization plus minus upfront support. You know, sometimes the patients are so sick, obviously we just put the Impella in right away or the balloon pump in right away. The next thing is to complete a full coronary and graft angiographic diagnostic study. In this case, we fixed the more straightforward graft lesion first. That provided some improved collateral flow to the infarcted territory. And then once the patient was a little bit more stable, given his persistent chest pain and his ST changes, we found and fixed the true culprit STEMI lesion. And that's it.
These cases are tough, and I think, you know, you guys handled it very beautifully. I don't think I could make out that there was thrombus in the left main with your first picture. It looked like a post-cabbage left main stump, so that's a really good catch. Any other comments?
It could be variations in how surgeons do it. I have never seen a diagonal graft be placed more superiorly on the aorta than an OM graft. So it makes me wonder whether there might have been 2 OM grafts, and maybe that more superior one had thrombosed perhaps that was actually the culprit. I mean, I
Right.
think you did the right thing, which would be fix the native, but it's unusual. Like I said, that would be an unusual configuration of the grafts, at least for my
Yes,
region.
that's what we had read in the CAP report later when we went on to find it, but I agree with you that typically that would be an OM graft that would be more superior.
So, Andrea, quick question. Why a balloon pump in this case? When was it done? Was it done like recently, then last year or something, this case?
What was your question?
Why the balloon pump as opposed to impeller in this case, especially with our guidelines right now is class 3 indication for
Right.
balloon pump?
Well, he had kind of small femorals. He was a smaller man. And, you know, at our hospital, we do tend to use balloon pumps pretty frequently. So our attending, who's very experienced, thought that that would be adequate support for this patient with less risk to his leg with the balloon pump device.
Did we see the EKG? Did you have an EKG in there?
We did not get the EKG from the VA.
And you didn't do one in the lab?
No.
Okay.
No. It was a pretty significant delay bringing the patient over to us from the VA hospital. And he was throwing up, too.
Well, I think our point is that it's a great question. What's the culprit? And, you know, what we'll always teach our fellows is trust the EKG, you know, and it oftentimes will give you some subtle clues, you know, to whether it might be more of a RCA and CIRC. It might not in this case, but certainly
Right.
an important piece of information.
Absolutely.
Having said that, you know, I work at the VA, and our main hospital is just across the street, and it might be faster to just push the stretcher across the street, but getting an ambulance and etc., it's quite the process.
Right. So the initial ambulance that they called is not the ambulance that they actually have to use to transport patients on drips. So they had to call the initial ambulance, then call a second ambulance, then, you know, get a flight nurse to accompany the patient.
The other comment is I don't see that you did any intravascular imaging here. I think it should be very helpful. You want to know, you don't have an EKG, and you want to know what is the culprit lesion here. All this, I know that it's a acute situation, you did a great job. You saw the previous case, it's a disaster with this sizing that venous graft.
Right.
I see that graft is okay results. I don't think it's very optimal results for the vein graft. But IVAS is very helpful too.
Yes, I agree. I think that's a fair criticism of the case. Thank you.
All right, thank you, Andrea. All right, let's have Dr. Kishor Khanal. What don't you see?
Good afternoon, everyone. Thank you, CVI, for this opportunity. I'm Kishor Khanal. I'm a current structural fellow at OHSU. I submitted this case when I was an interventional fellow at Arizona. I have no relevant disclosures, but I would like to thank my attendings, Dr. Lawton and Dr. Acharya, for helping me with this case to put it together. So this patient, we had a 75-year-old gentleman who was pretty symptomatic despite maximal anti-angiogenital therapy, known history of coronary artery disease with prior PCI, and significant cardiovascular risk factors. He had a CAP a few years ago that showed that he had a occluded optic marginal branch, and they attempted to revascularize, which failed. Given his symptoms, he underwent outpatient evaluation with the stress test that was quite significant with large ischemia mainly in the inferior lateral wall. And he was brought in for coronary angiogram. As you can see in the right, it was pretty unremarkable. On the left-hand side, the stents in the LAD were patent, but you can see the dissection in the second optic marginal branch and then the inferior branch of which is a CTO that fills retrogradely via left-to-left collaterals. So at this time, as he was pretty symptomatic, so we decided to try to intervene and attempted to revascularize. We were able to wire the superior branch, but the inferior branch was pretty difficult to cross. We tried multiple CTO wires, multiple microcatheters, but we were unable to cross. So at this time, we thought maybe we will just, and it was already a long case, so we thought we would put a stent in that distal segment of the superior branch and bring him back for that bifurcation stenting and try to recross the CTO at a later time. So that's what we did. First, we did the IVUS of that superior branch. So we did IVUS guided PCI in that distal branch, put a 225 stent and post-dilated 2.5 and post-IVUS, made sure it was good, and then we left it like this. So the patient the symptoms got a little bit better, but not significantly, as the large area of ischemia was still there when we hadn't fixed it. Patient was brought a few months later. The cath looks pretty much the same that we left with. This time, so this is after a few months, looks pretty much the same, the dissection, and then the CTO was there. At this time, we tried multiple techniques again, and same thing happened. We were able to put a wire across that superior branch, but the inferior branch could not be crossed, tried multiple microcatheters, wires. So at this time, we thought maybe it's the dissection flap that's preventing us to get into the inferior branch, and maybe if we put a stent across that superior branch, maybe it would give us some support getting into that inferior branch with the help of a microcatheter or an angled microcatheter. And that's what we did. So IVUS did again put a stent across that superior branch, did a nice proximal optimization, and then we were able to get into that inferior branch and then confirmed we had luminal. So at this time, after this, we IVUSed the inferior branch as well. We did the balloon angioplasty, opened the stent struts, and then decided, once we felt we were prepped enough, we decided to go into the inferior branch with the stent. We decided to choose a smaller stent because we knew we need to cover a longer area, but we didn't want to go with a longer stent because we were going through the stent struts and it's kind of a tortuous anatomy, so we didn't want to deal with that. But despite going with a smaller, shorter stent, we couldn't deliver it distally where we wanted. So we thought maybe we need to prep it more and we'll try to withdraw. So when we took the stent out, but what happened is when the stent came out of the body, only the balloon was there, and then the stent was not there anymore in the balloon. And then we were looking for it, so where did the stent go? So this is what happened. The stent actually was in the tip of the guide liner that we had. Luckily, it was distless, but luckily it was not free. And then when we pulled out the whole system, we could withdraw it, and then it got stuck at the wrist area. We had to make a small nick, but we were able to get it out of the body safely without leaving any fragments inside. But was that all? If you look closely, where the stent, we just had placed a stent and it came through the stent, look at that area. So what happened is when it came out, it actually had pulled the other stent together with it. That's why we had a hard time getting it out of the wrist, and then we had to make a small nick, and we pulled both stents out safely without leaving any fragments inside. But was that all? I guess not, right? So if you pay attention now, look at the stent where we placed a few months ago. That should have been endothelialized. That's usually what we see, what happens. We used IVUS. But there wasn't a stent anymore. It was actually the third stent that came out through the whole system, and all three stents were taken out safely. So that was the most surprising finding, because the stent that was placed a few months ago, which we did IVUS and everything to make sure it was okay, that actually came out. So this is what it looked like prior to distal stent, and I will play the image on the right-hand side. That is after when we pulled out the stent. So you don't see all three stents there. So it was all out of the body by then. At this point, we have TME3 flow. We're lucky, all three stents are out. So the decision, we could take a deep breath. No significant complication. Patient is asymptomatic at this time, hemodynamically stable. What would you do, right? There's TME3 flow, patient is stable, would you stop or go after it? Now you have wire access and everything. So at this time we thought, like, we already have access, we'll go back and fix it. But only difference is we wanted to go in a reverse manner, right? We didn't want to deal with that inferior branch again, so we decided to put a stent in the inferior branch first. We didn't have to deal with that angle, and then did a bifurcation stenting in the superior branch and did a final IVUS, and this is the result we got in the end. And the patient was followed up. The patient was doing much better without any angina symptoms at this time. Actually, he was off a few of his anti-anginal medications after a few weeks. So the clinical challenge. So we had multiple challenges in multiple states of this case, right? So we had difficulty crossing that CTO. It was already previously attempted. There was difficulty delivering the equipment, and dislodged stents obviously was the most challenging part. So we tried few resolutions of the challenges. We tried multiple wires and techniques for the CTO. Obviously, investment procedure helps. Like you can stop and bring the patient back later, and then you can formulate plan much better to move further for success. For difficulty delivery of equipment, you can use guide extensions and even supportive wires. And vessel preparation is the key. For the dislodged stents, one needs to be mindful. You always need to check if you have an undeployed stent that comes out of the body, you need to double check it to make sure the stent is actually there. And you have to be super careful if you are going back with the same stent. And the guide extension helps. And if the stent do get dislodged, then you need to know how to retrieve those. The techniques are important to learn. So key learnings, this was as an interventional fellow, this was quite a learning case for me. So stent loss is a possible complication, so optimal vessel preparation is the key, and try to avoid direct stenting. Image guidance is super helpful when you size the stent, and never push or pull against resistance. That's always the key in whatever cases we do, and always inspect the stents, as I said. But the most important thing is, even though you follow all these steps, sometimes you don't avoid this complication. It tends to happen, and you have to learn these retrieval techniques. As in our case, we never expected that 2-month-old stent would come out. So that's all I have. Thank you for your attention.
I'm curious why the 2-month-old stent, why do y'all think that? Was it the wrapped wire? You think that grabbed it and brought it back? Or?
I don't think so, but the thing is, when you put the other stent proximally, we always tend to, as we tend to hit the overlap segment, we did that, so we think maybe at that time when some of the stent struts went in between or something happened there rather than the wire itself, because the wire never got pulled when the stent came out, because it was the other stent we pulled out, and that inferior stent pulled the proximal superior stent, and that stent, I think, pulled it, because the wire was always in place.
I wish you had a flow storo of your pulling, because I would like to see how it all came out.
I probably had, but for the time's sake, I didn't put it here.
So just for me, I want to know what stents was that?
It was a synergy. So we put a synergy 2-5 post-dilated 2-5 based on IVUS. That was the first stent that we placed.
All of them were synergies?
All of them were synergies.
So how old is this case?
This is like, the second case was like December or January was when it happened.
Because in the beginning, when the synergy stents came out, there was some issues with the stents coming off the balloon, and then they redesigned the stent or something. So that's why I was asking.
Gotcha.
One last question, just a technical one. You put in tons of wires trying to go into that circ. What was the mode of failure? Was it going outside? Was it going subintimal? Was it not directed at all? Because that area, one of the biggest problems is that you cannot see where this is coming from, because it could be coming posterior, and your problem is the angle of attack. And resolving that is so different than changing wires, different. Or did it go subintimal and you guys didn't like it? What was the problem?
No, I agree with your point. So that's what happened. Because of that dissection flap, despite looking at multiple views, we were not quite sure where the actual ostium of that inferior branch is. And initially we were trying to go into the dissection flap, trying to find that lumen, and we're going outside the plane multiple times. So we're not quite happy to go there. And that's when the patient was brought in for the second time, the thought process of maybe if we can put that flap together, the stent will help and maybe we could go in. And then that made it much easier.
All right, we got
Great
to go on.
case.
Thank you so much.
you.
It was a really interesting case. Thank you.
Thank you so much. Thank you, everyone.
All right, moving on. Dr. Nicholas Pennza from silent to eruptive, complex PCI of calcified nodule.
All right. Hi, everyone. My name is Nicholas Pennza. I'm a second-year medicine resident at University Hospitals Cleveland Medical Center. On behalf of the coronary team at the Harrington Heart Vascular Institute, proud to present this case entitled From Silent to Eruptive, Complex PCI of a Calcified Nodule. I have no disclosures. So this is a case of a 65-year-old female who presented to our emergency department with chest pain in February of 2025 and rolls in for STEMI. Her pertinent cardiovascular history, she had a CABG at the age 44 with Lemieux to the LAD and RA to the PDA, both of which were known to be occluded at this point. The patient also had multiple OCT-guided PCI between 2015 and 2021, mostly to attenuate for LAD and stent restenosis, resultant layer of 3 layers of stent within the mid-LAD. The patient also had a PCI and stent placed in the left main at some point as well. Interestingly and incidentally, OCT pullback from these prior PCIs demonstrated a left main, non-critical, non-eruptive calcified nodule. So for this case of STEMI, this was the presenting EKG, most pertinent for some ST depressions in the lateral and inferior leads. And here is our diagnostic coronary angiography. So the interventional team denoted several key findings. Number one, the LAD seemed very patent with only mild ISR. Additionally, they could appreciate several layers of stents within the LAD as well as a stent in the left main as well. Additionally, there's a CTO seen of the osteal branch of the circumflex artery, and although not well seen here, a CTO of the RCA as well, but with good left to right collaterals. So for the clinical decision making, number one, this patient was deemed not to be a candidate for repeat CABG given multiple comorbidities, given patient's overall frailty. Next, the target lesion was considered to be within the left main, given the patency of the LAD, given the CTOs that we just discussed. So the team decided to approach the treatment with an intra-aortic balloon pump and OCT-assisted high-risk PCI of the left main. So the clinical challenge in this case is that of the calcified nodule, one of the more rare and more challenging lesions to treat with contemporary PCI. Only about 2 to 7% of obstructive coronary lesions are thought to be attributable to calcified nodules. And these patients have overall impaired clinical outcomes compared to different types of coronary lesions, as we'll soon see. So the non-eruptive calcified nodule, the accumulation of calcium with a overlying smooth fibrous cap, has an appearance of a smooth concave look on OCT, as we can see on the reference image here. Although this is often not the cause of ACS in patients, it is very challenging to treat with just stent deployment alone. Rigidity of the nodule is such that it does not allow for full stent expansion at that site. Ends up pushing the nodule further into the vessel architecture, expands more at the other side, and ends up in the ellipse shape of the stent overall. Now that is juxtaposed to the eruptive calcified nodule, or when there's a protrusion of calcium fragments into the vessel lumen, causing thrombus and causing resultant possible ACS. The treatment of this lesion has almost contradictory and paradoxical outcomes. On one hand, this calcium fragment that's now in the vessel lumen is very deformable, and we often can get full stent expansion at the site of this lesion. However, at both the immediate and long term, there runs the risk of this calcium fragment re-protruding into the stent struts, causing repeat cases of MIs. So these patients have overall higher rates of target lesion revascularization, as well as higher rates of cardiac death. To support the last point, a post-hoc analysis of the CLEAM study showed almost a 10-fold higher risk of death at 1 year for eruptive calcified nodules versus other types of coronary lesions. So tying it all together for our patients, the evolution of things over the years, we have the angiography and the OCT of 2015, 2021, and 2025. And we can appreciate in those first 2 years, we see that smooth concave appearance of this left main non-eruptive calcified nodule that one day in February of this year evolved in a bit of an atypical pattern to the eruptive states, from non-eruptive to eruptive, as we can see in the OCT in 2025, leading us to believe that this was the case of our patient's ACS. So for the procedural details, a 40 cc intra-aortic balloon pump was placed at the left common femoral artery, and a 6 French GBU was placed at the right brachial artery. There was successful 2 rounds of pre-dilatation with non-compliant balloons before a Synergy 4x20 millimeter drug-eluting stent was placed at the ostial distal left main. Post-interventional TIMI flow was also 3. So for the post-PCI course, the intra-aortic balloon pump was weaned to 1 to 3 and then eventually removed. The patient in the cardiac ICU tolerated DAPT with aspirin, ticagrelor without bleeding complications and was discharged several days later with hopeful follow-up with advanced heart failure and transplant cardiology. Unfortunately, this patient was lost to outpatient follow-up with our cardiology providers. But very interestingly, we can see in our EMR's records, this patient just a few weeks back in June of this year presented to an outside hospital with progress notes denoted as a left main end STEMI. Now, I don't have any angiography that I was able to pull over to our institution. There were no other PCIs attempted as well. But I think this really leaned into what our long-term prognostic worry is for these eruptive calcified nodules. Was this calcium re-protruding through our stent that we had just placed 4 months back? I think it very well could be. So the key learning objectives of our high-risk PCI, the left main for an eruptive calcified nodule, is that we had strong evidence of a non-eruptive left main nodule that laid dormant for many, many years, was never a culprit lesion, that one day evolved in an atypical pattern to the eruptive form, causing ACS in our case. And the challenge being to all providers is that optimal treatment of these eruptive nodules are much more difficult than we can usually appreciate. And there still needs to be a lot of work done to think about how we can decrease these higher rates of TLR and cardiac death in these patients. Those are my references. Thank you.
We have a little time for some questions. Anybody from the panel have any questions? I guess maybe I'll ask you a question. Would you guys have, what is your mode of support with these types of cases? Would you use hemodynamic support? Thank you.
Well, I think honestly, it would have been nice to see the angiograms, and that would have given us a little bit more thing as what actually happened. But I think we are still struggling, despite all the advances in calcium modification tools we have. Calcific nodule is still evolving, and hopefully future tools will help us. Thank you so much.
Our next speaker will be the topic, the Inaccessible, CTO by Dr. Mohammed Dabbagh.
All right. Hello, everybody. My name is Dabbagh. I'm one of the interventional critical care cardiologists at Emory. And as of a couple of weeks ago, I'm the CHIP fellow as well. So today, I sadly don't have any disclosures. I do want to give credit to my colleague, Nicholas Shaikh, but the brain behind this case is Wissam Jabber. So, we had this patient that came to us as a referral from an outside facility, 62-year-old, having chronic stable angina that's intractable to medical therapy, has history of CABG with a Y vein graft, both vein grafts to the LAD and the OM, and a vein graft to the RCA as well. He has CKD, diabetes. His EF is about 40% at the time that he presented to us. And so this is our diagnostic angiogram that we got from the outside a referring physician. You can see that he has a LED CTO, and his circ is a CTO as well, although there's a little bit of flow distally, so maybe there is a channel over there. This is our right-sided image. And I'm going to take some time trying to explain the anatomy over here because it's a little bit complex. I hope I have a pointer. So the RCA is a CTO, and you can see, I can tell you that it fills through a vein graft distally. But there's an atrial branch coming off of that RCA, and this is a caudal shot, so you can see the LAD filling from over here. And then that LAD fills a vein graft retrogradely that is supposed to supply that LAD. The Y vein graft that we talked about is osseally occluded, and because it's a closed system, blood is flowing back from the RCA to that branch, to the LAD, to the vein graft, to the other limb of the vein graft, into the circ. And so it's a little bit of a complex anatomy over here. And, you know, I took some time to draw it just so that we can, it was hard for us to imagine it, but we have an RCA, CTO, like I said, that's the atrial branch that fills the LAD, vein graft, backfilling flow, osseally occluded, and then you go into the circ. Both the LAD and the circ are occluded and are not receiving any flow antegradely. So, you know, we took the patient to the lab and we did our dual injections. And you can see the same anatomy, but a little bit more clearly over here. This is still a caudal picture, RCA. That's the atrial branch over here. And I think that's the LAD right over here. It's filling the vein graft in retrograde fashion, and then goes antegrade and fills up the circ over here. More pictures to clarify this. The RAO caudal picture. Again, that atrial branch fills the LAD over here, as you can see. And then there's backfilling into the vein graft, and then down to the circ. The vein graft to the circ, and then that fills the circ from there. And then our last pre-intervention picture is our REO cranial picture. And actually, that LAD CTO is a little bit more complex. You can see that there's dual occlusions, one over here and one more proximally. But definitely, you get the filling of the LAD first from that RCA, and that LAD fills the vein graft back, and then the second limb gets filled, and then it fills the circ. So, you know, the clinical challenge over here obviously is the anatomy, and the patient has already had a cabbage procedure. His lima is atretic, so a redo cabbage is not a real option over here. And, you know, how do we access that LAD without having any septal collaterals from an RCA that's also occluded? So, you know, the first thing that we did when we went to the lab, again, we actually engaged the left main, and we were able to send a pilot 200 down to that circ pretty easily. And we ballooned that circ, and we had antegrade flow through that circ. And this is how that looked like after that first intervention that we did. And we were able to wire a suo wire from the circ in retrograde to that vein graft that was supplying that circ. Next, we were able to drive that wire suo back to the ostium of the vein graft, and then we exchanged it for a pilot 200, and we were able to punch through the osseally occluded vein graft into the aorta, and now we had a floating wire into the aorta over there. So the next step, so before we go to the next step, just to kind of clarify where we are over here, we have an antegrade wire into the circ, went retrograde into that vein graft, and then it's now floating in the aorta at the ostium of that vein graft. So the next thing we did, we snared that wire into a JR4 guide, and we're able to actually drive that guide catheter and rail it into the ostium of the vein graft. And what that did is that it gave us access to that flush occluded vein graft and into, you know, the limb that's going down to the LAD. So after we had that access, you can see over here, hopefully, that there is a antegrade wire going down the vein graft limb to the LAD, and then we had a suo wire go back retrograde into the LAD, and actually that septal wire that wire is going into the septal branch of the LAD. So again, to this over here, we initially went down the circ, back into the vein graft, and then snared the guide into the ostium of that vein graft. The wire then went down to the LAD, and then we went back in retrograde fashion into the distal cap of the LAD. So at this point, we're engaging into the distal cap of that LAD over here. We're subintimal. We can't get into the to the lesion true to true lumen in retrograde fashion. So our next step was to set up for a reverse cart into to get into the LAD. And so What we did over here is we did not want to compromise the flow into the left main. So if we dissected into the left main, we could compromise the flow to the circ. So we set up for reverse cart into the LAD. We had a balloon in the proximal circ that kind of served us to let us know exactly where the LAD is starting, where the left main is, and so we did not want to create a dissection plane over there. We were able to, get multiple wires into that distal cap, Confianza Pro 12, Gaia 3rd, and a Apollo 200. And then we also had a wire antegrade fashion that was subintimal that went to the LAD proximally, and we set up for a reverse cart. The next picture that we have over here is kind of like a cine, and we're moving around, and you can see that there's that balloon in the circ, and we have the wire in the LAD, antegrade and retrograde, and they're both overlapping. They're in the same plane, and as this picture is moving, you can see that it's nowhere near that. Those two wires are not near that left main. You can see that circ balloon over here. And I'll let that play for a second just to see that. All right. So, last picture I promised from this, but now we have the wire going down the vein graft to the LAD, back into the distal cap of the CTO, and then we have an antegrade wire, and those are both on the dissection plane, and we set up for reverse cart over there. So once we had that, we were able to get a Gaia 3rd to enter the distal cap after we ballooned that proximal LAD for reverse cart, and you can see that the wire is actually puncturing through, and we moved it into a antegrade guide liner that was used to engulf that wire, the retrograde wire. And then once we had that, we had the case, and we converted it. We used an R350 to convert it into an antegrade case, and then we did a bifurcation stenting of the left main and LAD using DKT technique, and we have good flow to the LAD and to the circ. And those are the caudal and the cranial pictures. So the key learning points over here is that we had a complex disease. We didn't have a clear pathway for intervention initially, multiple CTOs going on, and we have a couple, essentially a branch off of the RCA that's supplying the rest of the heart. And so we use our understanding of the anatomy to try to come up with a plan, and it was all about preparation and planning for this patient. We did use a retrograde wire initially to snare the guide into a flush occluded vein graft. We've used that multiple times for ostally occluded RCAs, and so we had experience in that. And then, when we're setting up for reverse cart, it's sometimes easier to do it in a vessel like the RCA where you don't have a bifurcation. But over here, we use that blocking balloon in the proximal circ to make sure that we know where we are and we're not compromising the left main or the flow into the circ. All right.
Thank you so much. Any comments from the audience? From the panel?
Man, that's a great case. That's exactly what I was thinking. The only way to get it is through the circ. But let me ask you a question. How long did it take, and did you consider staging? Like if you go through, you can go open your circ, or even open up that SVG and then bring them back and then do the LAD instead of doing all this in the same setting. That may be the only thing that I would think of if I'm doing that case.
It's a brilliant question, and yes, there was definitely concern about staging this and just dealing with the circ initially. But the Pilot 200 flew through that circ, and so that kind of took a lot of the time away. And so it seems like a lot, but once you get that first challenge, I think when every step kind of moves forward, you don't have to pause anymore. But that was the initial plan, is maybe deal with the circ first and then to get the rest. I did mention that the patient had CKD and his creatinine wasn't great, but in these kind of cases, we had the original films. We took two dual injections. You don't have to use a lot of contrast, as you know, and because you have the vein grafts and you know the anatomy, you know you're in the right spot. As long as the patient's stable, you don't have to keep injecting just to confirm where you are.
My only comment is this case is a great example of how the vein grafts, even when they fail, can be useful.
Yeah.
Did you close the vein graft at the end?
That's a great question. For a while, we were doing that. In this case, we did not. Probably our thought process is that vein graft may close because it was already flush occluded, and so we didn't stent that ostium in the first place. And so, we kind of moved away from closing the vein grafts, especially if we're not worried about the flow of the native vessels. We think that the native flow will take over, and then it's not necessary to close those vein grafts.
How old were these vein grafts?
At least I want to say 10 years. So, you know.
It's unusual to see that much flow,
Yeah.
almost to the ostium in an
Yeah.
occluded vein graft, which presumably has been occluded for a while. They tend to thrombose, or they tend to
Yep.
not fill that well. I mean, you're very fortunate to have that.
Yep, that was very fortunate. And actually, the EF being only 40% with that kind of anatomy to get go also helped us in terms of occluding those collaterals.
Thank you so much.
Absolutely. Thank you. Thank you.
All right, our next free solutions for jail coronary wires. And I have the right doctor again, Laynie Abraham. Is it Dr.? Yes. Okay. You didn't change that. I know.
All right. Hello, everyone. I'm Laynie Abraham. I'm a PGY6 at Baylor University Medical Center, and I appreciate you all sticking around late in the evening to come to this talk. So I'm going to be talking about a case of a jailed coronary wire. Let me make sure I can do this right. Oh, there we go. I have no relevant disclosures. So the patient came to us as a 74-year-old female. She had stable angina that had been accelerating over the past 6 months or so, despite maximal tolerated medical therapy. She has a history of carotid stenosis, obesity, and hyperlipidemia that was well controlled. Based on her presentation, she was on maximal tolerated antianginals. We chose to take her to the cath lab. So here's pictures of her angiogram. On the left, you can see the RCA. She's got some mild disease throughout, and then a moderate lesion at the ostium of the PDA. On the right, you can see an areocaudal picture with the circ coming down. You've got severe stenosis of the ostial OM. And then our areocranial picture here, it's not terribly easy to appreciate on this picture, but you've got a mid-LAD lesion right below the takeoff of the second diag. There's also a LAO-cranial picture, which I didn't show here, but you can see it's kind of abuts the second diag, but it's below it. So our final interpretation was that she had a 60% stenosis of the right PDA, 80% of that OM1, and then a mid-LAD D2 bifurcation lesion, Medina class 010 without any complex features. Based on this patient, she's got multivessel disease, and we considered the possibility of CABG for her, calculated a Syntax score, which was only 13, so we decided to proceed with PCI. Although this isn't a true bifurcation, we did decide to protect the diag just because it was right next to the lesion. And so we proceeded here. As you can see, we wired both the LAD and the diag, and then ultimately chose to direct stent the LAD with a 275 by 18 millimeter onyx. And prior to any post-dilatation or proximal optimization, we pulled the diag wire and rewired. And actually, what we did not appreciate initially, but now is very clear to me, you can see that the distal wire does not appear normal. And so this was not something that we initially noticed. But as we went to pull the diag wire, we met resistance. So at this point, we're worried that we have an entrapped side branch wire, and so the clinical challenge is to discuss how to remove a jailed side branch wire. As you can see here, we took a zoomed in shot. You can notice a little bit of opacification of the stent that was not there previously, which we'll talk about here shortly. But we're going to kind of go through an algorithm modified by Dr. Brolakis, his algorithm, and talk about how to manage this problem. So we have an entrapped guide wire. The first rule is don't pull hard. I made a diagram of this just to help some of the early learners in the room like myself. What we think probably happened, just based on how the distal wire looked and the opacification of the stent, that probably the wire went through the stent struts. And as you pull, that will collapse the stent, which is what causes that opacification. And if you pull too hard, you can actually fracture the wire. So again, number one rule, don't pull too hard. Unfortunately, we ate too many Wheaties that morning, and we pulled a little too hard, and we fractured the wire. So now we've got a new problem, and the most important thing is understanding your wire position so you can know how to manage it. We took a zoomed-in shot here. This is an areocranial picture. So we've got the LAD coming across with the wire, as you can see, and then we think that the wire is probably unraveling. You can see where the arrow is pointing. Oh, sorry. That there is wire prolapse into the circ now. Just to confirm this, to make sure that we really knew where our wire was, we did wire the circ, we did IVUS, and we saw definitely there was wire now in the circ as well. So now we're dealing with not only an entrapped guide wire, but a fractured guide wire, an unraveling fractured guide wire. And again, I showed this diagrammatically. You can see the wire going through the stent struts. Now the stent is collapsed, and then you have unraveling into the circ. So the first question is, are you able to cover this with a stent? If you are, then you can just leave that fractured segment there. We felt like in this case, now this is going to be true bifurcation stenting, we felt like that was probably not the best option for our patient, but certainly something we could consider if we didn't have any other options. Another consideration is talking to your surgeons, can they help you bail you out of this situation if for some reason it can't be solved? We did talk to them. They felt like it was too proximal for them to approach, so that was not an option that we had. And so lastly, the next step is going to be to try and actually get the wire out. Because the stent struts were collapsed, we decided to inflate a balloon, try to open up the stent struts, and then as you can see in my diagram, if you open it up, you can potentially pull out the wire and then snare it. As you can see on the picture on the right, this is just one attempt of multiple attempts to snare the wire. It took several passes. The wire was prolapsing into the aorta, which made it difficult to fish out. But ultimately, we were successful at removing the wire. And this is the mangled wire after all that it went through. And then this is our last picture. We did do IVUS-guided LAD optimization. We put an additional stent overlapping that segment where we collapsed the stent. And here's our final picture. So the key learning points, number one, the main thing is try to not get in this situation. One way to prevent this is to proceed with proximal optimization prior to removing your side branch wire. That will prevent the rewiring through the stent struts. If you do have a difficult to remove jailed wire, don't pull too hard. You can use other techniques, taking a microcatheter down to that segment or a small balloon to provide some local traction, and that will help you more successfully pull the wire. If you do have an entrapped or fractured side branch wire, understanding its position is really key to knowing how you can manage it. If you can cover it with a stent, that's the preferred strategy. But if you're not able to for whatever reason, you can do other techniques, including what we did, which is inflating a balloon, snaring, and then the wire twirling technique as well. So I appreciate all your attention. Any questions?
That was a great case. Thank you. Yeah.
I just want to know what wire was that?
Oh, that's a great question. I'm not sure off the top of my head what wire it was.
I like the case. It's fantastic. The question I have for you is, when you pulled back your wire, were you pulling was the wire coming out of the guide but staying in the same position? Because if you've unraveled, you don't know how much you've unraveled. So covering it, say it hadn't been a bifurcation, covering it with a stent, you might not completely cover it. You might have some in the aorta or whatever. You just don't know.
Right, yeah.
So did you put that in your algorithm as one of the options, but if you're an unraveled wire, you have to be careful because it could be unraveled in the aorta.
Right, yeah. And that was one of the reasons too that we chose to try and remove the wire.
And this case is a great example why you shouldn't be jailing the knuckle wire. So that even J-tip, I'm not sure you're actually behind the struts, but sometimes the knuckle doesn't unfold easily, and so if the knuckle doesn't unfold, then before you realize this problem happens, you should start pulling just advanced microcatheter on the knuckle and take everything out. So it doesn't matter which wire, but basically knuckle wire, this can happen and fairly common. That's why we try not to gel them.
But was this the original wire that did this, or was it after you pulled back the wire and then you...
It was after, we pulled and then rewired.
Yeah, so I mean, the pod is obviously, as you say, is critical to prevention of that. Yeah. It will absolutely prevent it. And so imaging to know what size of the vessel. Yeah.
Thank you. Thank you.
Okay, and our last and final presentation is stent thrombosis of a protruding diagonal stent. And this will be from Dr. Rezkalla.
All right, thank you for having me here today. I'm an interventional fellow at Mayo, and I'd like to thank Dr. Galati through guiding me through this case. I have no disclosures. So it's a 79-year-old patient who comes in the middle of the night with an anterior STEMI. Only thing I'm able to dig up is that he had a prior PCI to a diagonal about 2 years prior, and that he's still on DAP for whatever reason. In this case, we opted to go 6'7" slender, just given that it was an anterior STEMI. Here's a picture of the right, and then we used a 7 XP35 guide for the left. Here you can see on the imaging it's hard to get rid of some of that overlap, but you can see the stent, that lucency proximal to the stent, and then on different angles here, we purposely wanted to visualize that stent in the diagonal and see what we were dealing with here. And so here's the clinical challenge is the more you look, you realize that diagonal stent is clearly protruding significantly into the LAD. Looks like we're dealing with stent thrombosis here, and it's a large diagonal branch. And so the first thought, as a fellow, I'm asked, what do I want to do next? The first thought was, well, there is preserved flow in both the branches, but the patient is on antiplatelet. Would a cabbage be considered here? I said, I think I want to proceed with stenting this, and that a cabbage wasn't warranted. So then I was asked, okay, what are we going to do? And how do you want to wire this? Do you want to wire around the stent? Do you want to try to wire through the stent? Are we going to do something with the diagonal, and how? So I encourage you to think through that, and then add the adrenaline of a midnight STEMI. This is what I was going through. Is this a case that we could just do thrombectomy? Could we just do a balloon, drug-coated balloon? And so ultimately, with some guidance, we decided to wire the LAD. We tried to pay close attention to going through the stent mouth opening into the distal LAD. And then since there was flow, we decided to try to take our time and try to get into the diagonal. First attempt here was just a run-through workhorse wire. You can see that it's going through the side struts of the stent. But the patient was stable, and so we continued to work through this with a run-through. Having it looped, we were able to go into the true stent opening into the diagonal. And so at this point, we paused, did imaging, used OCT, and we used it to understand the lesion, number one, and number two, to assess the wire position. So distally in the mid-LAD, we see some kind of thick calcific disease. As we come more proximally, we see red thrombus here in the LAD. Right at the bifurcation, we can see white thrombus, and I included the OCT stent markers. You can see that there's stent on both sides of the LAD at this point, so it was really significantly protruding. We quickly did 3D, and you can see here that the LAD wire is actually going through the opening of the stent, and that the diagonal wire is also going through the opening of the stent. So this made the procedure a little bit easier, and now I think as an earlier fellow, I was able to understand what we were going to do. And so the next step was to kind of configure this into like a culotte. So we, with the wiring position, we did sequential branch dilations, kissing balloon inflation, and then opted to do, so here's the LAD dilation, here's the diagonal dilation, our first kiss. This reformatted the diagonal protruding stent, and then with the diagonal stent as the outer layer in the proximal LAD, we put a 3.5 by 32 synergy going from proximal to mid LAD. We actually just switched the wires to avoid the complications like we did in the last case. Did our second kissing balloon inflation, and then did a pot and kiss pot here. And then to finish the procedure, we did a drug-coated balloon into the diagonal. So this was our final result. There's 2 layers of stent in the proximal LAD. You could see the culotte formation there and how it turns into a single layer stent in the more mid LAD. And then just taking the lumen views, we can see full stent coverage of the carina and kind of resolution of patients' pain and symptoms here. And this was our final result. So the takeaways for me, I learned several things on this case, but one thing for anterior STEMI, if feasible, I think consider using a 6-7 slender and a 7 French guide. It seems like all the PCIs we're getting into are more complex, and it almost always is involving a bifurcation in our anterior STEMIs. Take a deep breath in, as it's been mentioned several times throughout this session. We had preserved flow. Try to think through your treatment strategy. And then try to just break down the procedure into steps. So first, it's overwhelming. You see stent thrombosis, protruding stent, but if you just take it one step at a time, we ended up with a DK culotte here. And once you go through that, you can once you break it down into something that you know, it's a lot easier to proceed. And then lastly, use your imaging to its full capacity. So we know how we figured out what the lesion cause was. 2, we figured out additional modification. 3, we were able to figure out and delineate our stent configuration. So thank you for having me.
Yeah, very interesting, challenging, obviously. From many of the studies and bifurcation registries and randomized trials, one of registries mostly, the main driver of stent thrombosis and bad outcomes in bifurcation, 2-stent bifurcation stenting, is the presence of a STEMI or ACS and thrombus to begin with. So it's very challenging. You had a very challenging situation. The LAD itself didn't have much disease, did it?
Yeah, the more mid portion, the MLA was, I think, like 5.6.
Yeah. So
I
mean,
so
at least
too
in
bad, but the thrombus did involve the proximal portion of the LAD.
For sure, yeah. I suppose another way you could do it to minimize the amount of metal is to crush that stent and then to recross and do kind of a reverse crush without actually stenting the LAD, and at least let this cool off, let it settle down. It's tough, but that might be another way to do this, and you minimize the amount of metal you put in a thrombotic situation. But nice result.
Another reason why we shouldn't try to nail the osteum.
Mm-hmm.
Working. This is another example why we shouldn't try to nail the ostium. What we should realize is what we do in the cath lab is very imprecise and imperfect despite us trying our best. So that's why you should always factor a margin of error. So when you're trying to nail the diag ostiums, stent can move back and forth. Either you miss or hang too much. So we could have probably prevented this acute MI if the operator had just stented back to the LAD and just spotted the proximal part of the stent.
Especially a low-angle bifurcation, right? Mm-hmm. Yeah, which most LAD diagonals will be.
So you guys would have, let's say the original procedure, you're saying you would have put the stent all the way in, even though the LAD wasn't diseased?
You just cross over.
Yeah.
That's actually the simplest way to do this and the safest way.
Yeah, no, I hear you. I always have a problem with doing that with an undiseased LAD as opposed to a LAD that's diseased.
Yeah, so all you have to do then is image the distal segment to make sure you've caused no dissections. You obviously recross, you kiss, and usually it looks very good and has a good outcome.
And that's probably the reason why, if you look at the bifurcation trials, 001 Medina classification, those lesions have the worst outcomes because we cannot be perfect at nailing the ostium. Either we miss it or hang too much or we crush too much. So that's probably the reason. So that's why even if you have 001, it's probably safer to just stent back to the main vessel and pot and recross kiss.
thank you, and congratulations to all of the presenters. Really excellent work.